And then Maya, I don't know if you wanted to say anything too. But I'm Alexis. I'm a third year biology and French major at the University of Chicago. But I'm originally from the Bay Area in California. And I'm the current president or the current co-president of MED-UCATE, which is a community service sort of education-based organization that has multiple chapters, both in colleges and high schools across the United States, because our founder actually made this organization when she was a high school student and realized that she wanted to increase sort of like science and health and well-being education among younger students because she noticed they weren't really getting that sort of learning until way later. And because of that, like they didn't necessarily know how to take care of themselves. And also if they knew they were interested in, or like they couldn't figure out they were interested in medicine until way later because they were never learning about like the body systems and pathology and health and well-being until it was too late. So this organization was founded to like teach sort of like anatomy and physiology programming at elementary schools and libraries and after school programs in our different chapters. We have USC has a chapter, like this set of Bay Area high schools has one. University of Chicago, of course, has one, and then we have a couple of colleges in the East Coast too. And today I wanted to like I can tell you more about what our organization does because I know most of you will probably be going off to college soon. And while we sort of the way Meducate works is if anyone wants to form a chapter at a new college that doesn't currently have one, like we'll put you into contact with our board and see like what sort of what your plans are to reach out to your community and help you work with that. So I thought this would be a good opportunity to tell for me to tell you guys what we do in case this is something like you want to start up on your own because we're not at that many colleges in the US. So likely it's more likely you'll go to a college that doesn't have one than one that does. And then I also wanted to give you guys like an example of a high school level class we would teach that we recently did in the Hyde Park area in Chicago. This could be review for some of you, could be new. I'll keep it brief, but just for you guys to get a sense of what we teach and maybe learn something cool about sort of like the cardiovascular system and vital signs. Maya, did you want to say anything?
I think that pretty much summed it up, but yeah, I just wanted to say thank you to everyone who joined. I know most of us are like high school students, just a few of us are in eighth grade. And
Mm-hmm.
yeah, we're really interested to know like what your organization does. And also we're also really happy to learn about vital signs and things like that. So yeah, thank you so much.
Mm-hmm. Perfect. Um, I will, before I get into like the little lesson, I'm going to share my screen and show you guys our website if you want to check us out. So give me a second. Okay, so we are like med-ucate.org. And you can see here, if you like navigate on our website, that we partner with different, like I'll show you the ones in Chicago. Like for example, we have teachers, just students, like college students who go to 7 different sites every week, like 1 hour classes, and we prepare our own curricula and teach them, and we bring hands-on activities because given that we're working with students ranging from K through eighth grade, um, we think that the lessons will be more impactful if they have hands-on learning components. And because it's not part of their normal school day, like kids might be less motivated to retain the information if we're just lecturing at them. So we always try to make sure that our classes have a big activity component to them. For example, like we teach at this program called City Elementary, which is tailored for like neurodiverse kids who have different developmental needs. And so a lot of the learning is project based. And we teach them not, like it says here, not just anatomy and physiology, but also different life skills too. HPNC is another program that we do. It's an after school program. And we've had this partnership ever since I started my first year at University of Chicago. And then these are different programs that operate, I think, in our like Southern California chapters as well as on the East Coast. So I'm not as familiar with them. But one thing that's cool to note is that Meducate also has online programs. So we developed a Ukrainian language module about health, and we're currently working on translating it to English to be able to use it at elementary schools here too. But we have like for anyone who's interested in having a wider outreach, they like we create content that is accessible online. We also do sort of similar to what you guys do with Teen Health Journals. We have careers in medicine, so we invite physicians to talk to high schoolers through our programs more about their specialties and their pathway towards them. And we have a blog as well where any student who's interested can write about topics in research, biomedical research, or clinical medicine. And let's see what else is worth saying. There are lots of ways to get involved. Even if you don't end up founding your own chapter, you can help us with our social media. You can help with designing curriculum, even if you aren't the one teaching it, because we're always looking to not modernize, but just update our sort of like our online content. And here you can see some programs, pictures of our students who went to these different sites and taught. It's been a wonderful organization to be a part of. And if any of this sounds interesting to you and you're curious about how you can, when you go off to college, get involved, or even like as a high schooler, how you can get involved, please let me know. And I'm happy to talk to you and also put you in contact with our founders who are more involved with helping people start their own chapters if they're in an area that doesn't have MED-UCATE. Yeah. Does anyone have any questions about us as an organization before I get into like the little lesson? Okay. In that case, can I ask how many of you have taken like an anatomy class so far? Or learned about the cardiovascular or pulmonary systems, just so I have a sense. None of you, right? Okay, awesome. That's great. Then it'll be new. Okay, lovely. Okay, you guys can, oh wait, this like bar at the top is still visible, right? I need to move it. Okay, perfect. The the like side panel with everyone's faces isn't blocking anyone's view, right? Okay, cool. So this is a class that we taught at UChicago about a month ago when we had a lot of high schoolers come and like different clubs at our school were invited to prepare content for high schoolers. So we obviously talked about medicine and specifically set the basis of the cardiovascular and pulmonary systems before getting into, in an emergency medical context, what are ways like even people who are untrained can help identify like a cardiovascular emergency and sort of take vitals and potentially like inform a life-saving treatment. Because a couple of kids in our group are also EMRs, EMTs, myself included. So it was cool to work on this presentation. Okay, how do I go forward? There we go. We can skip that. That's normally when we have younger kids. Okay, guys. So the cardiovascular system is composed of not only our heart, but also our blood vessels. So we have our arteries, which are carrying blood away from the heart, our veins carrying blood back towards the heart, and capillaries are sort of like the smaller branches of our arteries, because as they move like throughout our body, it goes from arteries to arterioles to capillaries. And capillaries are the site really of oxygen and carbon dioxide exchange between our blood vessels and our tissues. So as you can see in the diagram, the red is sort of showing the oxygenated blood that's coming. So the blood goes from the heart to the lungs to get oxygenated and to distribute carbon dioxide and other waste products from the tissues. Then the blood comes back to the heart and then is pumped to the rest of the body. So when it's pumped to the rest of the body, it's oxygen rich. It helps our muscles and our organs carry out respiration that they need to go through their normal bodily processes, and then picks up carbon dioxide, takes it back to the lungs, and then they're exhaled, like all these waste products. So I'll show you a better diagram later. There we go. The heart, as we know, is located in our thoracic cavity. So we have like two cavities in our torso, the thoracic and then the abdominal down below. And the diaphragm is like the sheet of muscle in between our thoracic and abdominal cavities that we contract and sort of relax when we're breathing. And the heart is the size of your fist. So depending on how old you are or how big you are, like that's probably a good estimation of the size of your heart. And it weighs around 0.5 pound. This is like in an adult male, not the same for everyone. Okay, and if you see this diagram, it's not as much to the left as you'd expect. It's pretty close to center, actually. Okay. We have the pericardium, that's a membrane surrounding the heart. It has different layers. The epicardium is the outermost layer, followed by the myo and the endo. And myo is a prefix that refers to muscle. So you know that's where the cardiac muscle is located. And then the endocardium is the innermost layer. I showed you this before. I wonder if you'll ever do I took AP Bio during COVID, so we didn't get to, but in a high school biology class, you might get the chance to dissect the heart and see probably from a baby pig, I would assume, and you can see sort of like the pathway of the blood. Is this diagram familiar to anyone? No? Okay.
Um, yes,
Yeah,
it
go ahead.
is.
Yes. Um, Anyone else? That's okay. I'll talk you through it. So this blue represents the like superior vena cava. So vena cava also refers to vein. So I said earlier, vein is like the pathway of blood coming back to the heart from the body. So there's both the superior vena cava. You guys can see my cursor, right? When I move it like this. Okay, so there's the superior vena cava and the inferior vena cava. So it depends on if the blood is coming from like your anything above your heart, like your head and the neck and like shoulders and arms, or anything below the heart. So legs and torso, pelvic cavity, everything like there. And it's blue because it's deoxygenated and rich in carbon dioxide. It will come into the right side of your heart. It will follow this pathway down. So the heart has four chambers. This small little chamber is called the right atrium. This bigger one is the right ventricle. This one is the left ventricle. And then this little thing is the left atrium. So the blood comes from the body to the right side of the heart. It's pumped through the atrium into the right ventricle. And then this is the pulmonary artery because the blood has to go to the lungs now. So you can exhale the carbon dioxide and pick up oxygen from the atmosphere. Then the blood will come back into the heart through the lung from the lungs. So that's called the pulmonary circulation system. And now it's red because it's oxygenated and it will go through the left atrium. Sorry, this way. Sorry, through the left atrium, left ventricle, out. The aorta is our biggest artery in the body. So it's very dangerous if you ever are wounded there because there's very high pressure blood coming out. And it's just like you will like quickly hemorrhage if this part of the if this artery is in any way injured. And then this is pumping blood to the rest of the body in like a branching out system. So obviously it starts like one big artery, but then becomes arterioles, becomes capillaries, and gets to the different tissues of our body. There are valves that separate the right atrium and right ventricle, as well as the left atrium and left ventricle, as well as the like ventricle to the pulmonary artery or the ventricle here to the aorta, because you don't always want blood flowing. Essentially, like you don't want blood going from the ventricle to the pulmonary artery until the ventricle has fully filled up. So you only open one valve at a time. So first it's this one to let blood flow from the atrium down to the ventricle, and then it'll close, and then the pressure is big enough in the right ventricle that it'll get pushed out into the artery and force the valve to open. So it's that's what kind of causes the like when you hear a heart rhythm, it's like lub dub. It's like okay, the lub is like this valve, the tricuspid valve, and the mitral valve closing first, and then the dub is the next two valves, the pulmonary valve and the aortic valve closing next. Does anyone have questions about this diagram? It's not important for you to memorize it, but just to get a sense of like what is the relationship between the heart and the lungs in oxygenating blood? No? Okay, we can go on. So this is sort of the same depiction of we have the valves that separate different chambers of the heart. I can skip forward. Yeah, these are just some more images. So like you can see here, the aorta fills first, then it spills into the ventricle, and then the ventricle contracts and forces blood through one of the arteries, either the pulmonary artery, this one, or the aorta, this red one. Okay, this is basically saying the same thing. Any new terminology? Yeah, I guess pulmonary circulation, like I said, it's going from the right ventricle to the pulmonary arteries and then coming back by the left atrium. And the systemic circulation just refers to the rest of your body, meaning that this is blood coming from your left ventricle to the body through the aorta, and the blood comes back to the heart through the vena cava into the right atrium. And this diagram kind of shows it all spread out. Yeah. Okay. Let me know if I'm going too fast or if anyone has questions. Just like stop me because I can't see everyone's face at the same time. Yes, go for it.
I have a quick question. I heard there's like some like new like biotechnology like or something like that where they like kind of discovered that for like some like heart transplants they actually use like a pig heart. Like,
Mhm.
have you heard of that? And like, how does it work? And if there's like any like side effects or anything?
What I know about this is they don't fully replace the human heart with a pig one, but they replace the valve of the human heart with a pig one because some people have like mitral valve insufficiency. Like, let's see. Oh, how do I go backwards? Uh, oh, wait a minute. Let's see. Okay, mitral valve, this one, between left atrium and left ventricle. Basically, their valve doesn't fully close, which means that when the blood in the atrium goes into the ventricle, like it's not supposed to backflow into the atrium. It's supposed to just keep going through the aorta into the rest of the body. But if their valve like isn't fully closing, likely due to muscle weakness, like then they have backflow of blood and I actually don't know the symptom. I think you have chest pain that's pretty severe and that needs to be replaced. And so we can replace it with valves from a pig's heart, um, which is pretty interesting. I think also like what else have I heard of? Let's see. We'll talk about this later. Like when you have like atherosclerosed arteries, meaning you have plaque buildup in your arteries, and you sort of have like necrosis of a part of the artery, meaning like the tissue dies. Like that can also be replaced with parts from a pig. I think also cow parts have been used in these kinds of surgeries too. Yeah. There was more to your question, I think.
Like, would
Or
there
was
be
it?
any like side effects or like complications?
I see. Do you know that's a great question because I don't know how our immune system would react to pig because we don't have the same like HL like antigens that are like I don't know how we would be able to detect it as self versus non-self. My guess is like whenever you have just like stem cell transplant of someone who well, first of all, yeah, when you have stem cell transplant, like they should have the same like HLA, it's like human leukocyte antigen on their cells so that our immune cells don't immediately attack them. But you still like have to put someone on immunosuppressants to like tone down their immune response. Like my guess is that's the same thing that happens. Of course, the side effects of being on immunosuppressants is if you like are exposed to bacterial infection or viral infection, like it's much more likely to be complicated and leave you hospitalized. So those are downsides to it. Yeah, so I guess yeah, your body rejecting a foreign like that's always the danger of surgery and transplants. Yeah. Yeah, that was a good question though. I'll have to read more about that. Okay. What do we talk about? So veins always go to the heart. Arteries always go away from the heart. However, there are some exceptions. Like you can't memorize like an artery is always carrying oxygenated blood because actually when there's a mom and a baby developing in her uterus, the baby has to get oxygenated blood from the mom. And so because veins are always going away from the heart, and so they're going to the baby's heart, but they're carrying oxygen. Like technically, those veins are oxygenated, and then the arteries that are leaving the baby and going back to the mom. Wait, am I saying this right? Wait, let me think about this. The vein is coming to the baby's heart. Oh, I mixed up. So let me say it one more time. So you have a pregnant mother and a baby in her uterus. The baby's veins are coming to the baby's heart and they're carrying oxygenated blood from the mom, and then the arteries are leaving the baby's heart and going into the mom's circulation and carrying deoxygenated blood. So that's actually an exception to what we'd associate with like veins always being oxygen low and arteries always being oxygen rich. But otherwise, in like a non-pregnant person, the veins carry deoxygenated blood, arteries carry oxygenated blood. Yeah. Okay, here is one example of like cardiovascular pathology. It is called CAD or coronary artery disease. The coronary arteries are supplying oxygen to, because it's not just our body tissues that need oxygen, but the heart itself does too. So part of the systemic circulation actually involves like feeding oxygen into the muscles of the heart that allow it to contract. So these coronary arteries are supplying to the myocardium, which I mentioned is the middle layer of the heart muscle. So you can see here, like this plaque is just a buildup of like a fat deposit. that prevents the flow of blood. And so the muscle ends up, like, because of lack of oxygenation, ends up atrophying and dying. And then the heart, like the blood pressure will decrease and the heart rate will decrease, and the person will have trouble breathing and trouble going through daily activities, and can eventually have like total stoppage of blood flow, which can also cause seizure, and stroke, and death. So lots of horrible things with artery blockage, which can be avoided with sort of like consistent exercise, proper diet, low intake of cholesterol. Also, like, you can take medications if you're high in cholesterol. You can take anticoagulants to break up the blood clot. But yeah, this video, we'll skip this one because I've been talking about it. Okay, questions. And we have an activity coming. Don't you worry. Before I go on to the lungs briefly, this won't be as in depth. Okay, so the lungs, the respiratory system, obviously starts from the nose and mouth, then goes into our trachea, or known as our throat. In our pharynx, sorry, trachea is not the throat. The pharynx is the throat. There are two pathways for anything in our mouth and nose. It could be like food particles, which obviously go into our digestive system, and air, which goes into our respiratory system. So when we swallow, like the epiglottis, it's like the little hangy thing in the back of our throat, like that actually covers the trachea, so that food will only go through the esophagus and the digestive system, and so that food won't go into the trachea and make us choke. Sometimes that doesn't work though, but most of the time that's what it exists to do. So assuming we're breathing normally, we're not getting food into our breathing systems, the air will go into our trachea and then break out into the two bronchi, the left and right sides, then split up into the bronchioles. So the bronchi is like this big thing, then the bronchioles are these like smaller offshoots. And then finally, we have the alveoli, which are these small air-filled sacs that are in very close contact, like within a millimeter of a lot of capillaries, which is facilitating this like diffusion of oxygen from the alveoli, which are air-filled sacs, into the capillaries, which are then forming the veins that come back to the heart. And then, yeah, we can see here our ribs that are covering. Yeah. Okay. So I showed you this. Oh, it's because it's hidden. Wait, give me a second. I think some of these slides were hidden. I don't want that. Respiration. Okay. Let me share it one more time. Oh yeah, there we go. Pharynx, larynx, trachea, bronchia. Okay. So like I was saying, this is a little alveolus. This is the blood, and then we want CO2, carbon dioxide, leaving the blood, and oxygen going into the blood through diffusion. And like I mentioned, the diaphragm is an important muscle separating our thoracic cavities. Oh, I realize you can't see me. Like the diaphragm is just between the thoracic and the abdominal cavities. And when we're inhaling, the diaphragm is it's actually contracting, and that causes it to lower. And that, like, okay, let me set this up in an interesting way. This is how I learned about it. Like, we think that we inhale first and then our lungs expand, but it's actually because our lungs expand that we can inhale. The reason this is because when we're breathing, our diaphragm, like when we're inhaling, our diaphragm contracts, causing it to flatten, which opens up volume in the lungs. When you increase volume, the pressure goes down because the air particles in our lungs like have more space to go around. They're not hitting the sides, the walls of the lungs as much. Because we have decreased pressure, pressure always flows down a gradient. So that causes the atmospheric pressure to be higher than the pressure inside of our lungs. And so air will flow from the outside into our lungs. So it was the expansion of our lungs that caused us to inhale, not the other way around. Then when it's time to exhale, our diaphragm will relax. It was lower, but it was flattened before. It'll like come back up to be this little bridge that will decrease the volume inside of our lungs, increasing the pressure inside of our lungs. And because gas always flows down its pressure gradient, the gas will be expelled from our lungs into the environment. And there are also other muscles that help, not just the diaphragm, including our abs when we're doing like really active exhaling. And we have like these muscles in between our ribs called the external and internal intercostal muscles that are assisting in inhalation and exhalation, respectively. Okay. Um, Different vital signs. So for anyone who is interested in like emergency medicine, like a cool experience you could start even at the high school level, but college is definitely not too late to join either, is being an EMT or an EMR, emergency medical technician or emergency medical responder. And what I've learned in my training is like the basically the not the holy trinity because it's six, but like the six most important vital signs that you should know how to take and know how to identify are the following. So three are associated with the lungs, two with the heart, and one with just your pupils. But I'll explain those. So first thing, pulse oxygenation. That is just telling it's just telling like the percentage of your red blood cells that are carrying oxygen molecules. You want that to be above 95% for any patient. If it's below 95%, they're in what's called respiratory depression. They're not either like having a lot of difficulty breathing, they're not able to release carbon dioxide and pick up oxygen, their red blood cells, I mean. You likely need to put them on supplemental oxygen, like give them a nasal cannula, attach them to an oxygen tank, or like a more serious, like it's called a non-rebreather mask, to get them to get that pulse ox back above 95, because otherwise they could stop breathing altogether, in which case you would definitely need to call an ambulance. So pulse ox is pretty easy to detect, actually. It's like a little, I don't know if anyone knows what it looks like. I can show you. Let's see, pulse oximeter. Yeah, it's this little device that you just clamp on your finger. And it actually tells you your pulse too, like your beats per minute of your heart, which is nice, but you more just use it to tell you the percent O2. So that's the range. It's a reading that takes maybe like 5 seconds max. Yeah. And it doesn't prick the person. It's just shining light through your finger. And it's detecting absorption of light by your blood, which indicates the oxygen level in the blood. That one's an easy one to do. And then respiratory rate is just like for adults, it's like 12 to 20 is a normal breath per minute. Anything below or above means they have really labored breathing or really rapid breathing, and that's a concerning thing too. And then you can take lung sounds with a stethoscope. You just feel like above, you feel like right here, just right below sort of the sternum, and then you just feel 4 spots in the back. So it's like 4 in the front, 4 in the back, and then 2 on the sides. You just ask the patient to inhale and exhale, and you want to detect like there are 4 different kinds of bad lung sounds: wheezing, stridor, rhonchi, and rales, which could be like crackling, could be this weird wheezing sound. That one, I think we kind of know what it sounds like, but I can actually show you because I have this video pulled up. Let's see. Everyone can hear that, right? I'm gonna just skip to where it says.
For some reason, I
Yeah.
don't think the audio is shared, so
Oh, interesting. Let's see. Open share. How do I do that? Oh, share sound. Let's try again. Can you hear that?
Wait,
Yeah. Yeah.
yeah.
Okay, lovely.
the sound of
Let me go back to that one then, because I want to show you guys what it sounds like. So Strider, yeah, you hear it when they're inspiration, yeah, which means they're breathing in or inhaling. So let me play that one. And then wheezing that's like someone who's wheezing, like think of someone who's asthmatic having an asthma attack, like they're because of like their immune response, their airway has kind of closed or has been partially obstructed. And so it's like this whistling sound that goes by as the air is trying to be forced through their obstructed airway. Let's see. Where's that one?
expiration. It may be heard in asthma, emphysema, and chronic bronchitis.
And crackles. Those are interesting. Um, that could be if you have an infection in your lungs and you have just a lot of mucus that's accumulated. Yeah, for example, bronchitis. Bronchitis refers to inflammation. Let's see, in the lungs. Yeah, so you hear the little crackling of it. Okay, let me do. I can't see you guys anymore. I don't know why. You guys will just have to let me know if you have questions because for some reason I don't see your faces anymore. Yeah. Okay. No, I don't want that one. Alrighty, and then the heart. So there's the heart rate, which you want it to be like 60 to 100 resting, but then essentially like max heart rate for a 20-year-old when they're exercising is 200, and then every age range below that, it just kind of decreases by like 10 beats per minute. So you would be concerned, for example, if a 60-year-old like after exercising had a heart rate of 200 beats per minute, because that's really only the max for like 20 to 30-year-olds. And you can detect heart rate by like just feeling. There are different ways. Like for a baby, for example, like you don't want to feel the radial pulse. You want to do the brachial pulse, which is just like the pit here. But like you just put two fingers, not the thumb, because the thumb has its own pulse, which will interfere with your ability to feel the pulse here. And it's like on the side of the patient that's closest to the thumb, not on the other side of the hand. And there you can't see because it's like really bright, but you have this these two tendons here, and you kind of want to put your fingers right next to, like, you want to put the pads of your fingers on those tendons, but then the actual tips of your fingers right past where your thumb is. And you just press down until you feel your pulse. And the way you take it is you have a timer that's like for 15 seconds and you count how many beats you feel in the 15 seconds, and then you just multiply by 4. There's no reason to do it for the whole minute. And that's their heart rate. It's also really easy to do it right behind the neck. Let's see. Or not right behind the neck, right? Let's see. You want, so this is like right in the middle of my chin. You want to go, it's not quite lined up where your ear is and like where the jaw is. It's a little bit between there, and you just push. Let's see, am I finding mine? There we go. Yeah, that one's pretty obvious. But generally it's preferred to do this one. I just think because it's like more uncomfortable for you to be doing that on someone else on their neck. So you can just do it in the wrist. Yeah. Okay. And then what else do we have? I'm not sharing my screen anymore, am I? No. And then blood pressure. So oh, I had it here. Let's see. So we have, has anyone ever seen a blood pressure reading like that? Did you guys know that it was two numbers? If not, I can tell you why. It's called our systolic blood pressure over our diastolic blood pressure. So when our aorta pumps blood to the rest of our body, the pressure is really high because it's about to send blood on a mission to the whole body. So like the heart is really pushing. Pressure is just like, it's just the force of the blood over the area of the walls of our vessels. So it's highest during like this contraction. And then when the ventricles, like they've pushed out all their blood, they've sent it through the aorta or the pulmonary artery to go to the lungs. The ventricles are now empty and they are just waiting for the next cycle of contraction because blood is refilling from the rest of the body and from the lungs. And so the pressure is now much lower. It's not zero, but it's just lower than it was during that contraction phase. So this is just the filling and relaxation phase. So that's why we have two numbers for blood pressure. 120 over 80 is normal, but it can be varied around that before it becomes concerning. Like, I thought I had a diagram. Hypertension is what we call high blood pressure. Hypotension is what we call low blood pressure. And you can see here that basically, like, if you're below 120 and below 80, that's generally normal. It's when you start to get kind of like 10 digits above 120 that it becomes concerning. There are different stages of hypertension. A crisis is considered when you're 180 over 120, and you definitely need to be hospitalized for that. This unit is millimeters of mercury. That's just a unit of pressure, which is like force divided by area. Let's see, how do we do this? I don't have like a stethoscope on me now, but there's like, if you've ever been to the doctor's office, they probably just have an automatic stethoscope. It's less accurate, but it's more convenient. Like they just wrap the thing around, like the cuff around your arm, and it just squeezes and releases, and then the meter just reads your blood pressure. But it's more accurate to do the manual way, surprisingly, where like you wrap the cuff still around your arm, you use a stethoscope, you slide it underneath the cuff, and it's kind of just pressing over this artery that I was mentioning that you use when you want to take babies pulse. Yeah, go ahead with your
I
question.
was wondering if there is another location to take your blood pressure beside your arm.
Oh, good question. You can take your blood pressure. Let me think.
I'm currently in like a
Oh,
CNA
yeah,
class, so that's
yeah,
what
yeah.
we're learning right now.
Oh, wow. Wait, have you learned about another place?
No,
Let
not
me
actually,
see.
but I know you like some doctors, they can take your pulse ox like on your toes or
Oh,
earlobes.
yeah, for
Yeah.
sure, for sure. But yeah, in terms of blood pressure, let's see. I don't see why you couldn't do
Mm-hmm.
around the pelvis. Like there's a lot of blood flow there too. I just don't the issue is it's difficult to like the pressure gets really high when you do. Yeah, question. Nita.
I heard you could take it like around your ankle, but I'm not sure.
Uh-huh. It seems like I'm just looking it up now. You can take it around your ankle. You can also take it around your quad muscle, like your thigh. That works too. Interesting. I don't know why you would do one versus the other. Maybe if like it's a traumatic scenario where their arm is not available for this, like they've, I don't know, they have a gunshot wound to the arm or whatever, then you would do it elsewhere. But I think the first measure is in the arm. Yeah, that was a great question though. So yeah, basically you just like you increase the pressure or of this cuff to be like pretty high, like maybe like 160, 180 millimeters mercury, and then you like slowly open the dial to release the pressure, and you just like notice when you feel in the stethoscope, you hear the full first pulse, and you want us like the pressure at which you hear that first pulse is your systolic pressure, and then the heart will keep beating and beating and beating, even as the pressure is going down. Eventually, it won't beat anymore, then you know that's a diastolic pressure, and then you can relieve the patient by turning down the pressure all the way to zero. But yeah, okay. We talked about high blood pressure. We talked about heart attack. Well, we kind of talked about heart attack. Heart attack is often caused by atherosclerosis. So yeah, plaque buildup in the arteries. There's like suddenly a lack of blood flow going through the heart, supplying the muscles of the heart. That's why it's so heart attack is also called myocardial infarction because myo refers to heart muscle. Okay, I want this. There we go. Symptoms differ from this range. So you could be having a heart attack and not have this set of symptoms, but chest pain is very likely to occur with a heart attack, as well as difficulty breathing, lightheadedness, nausea. Yeah, pain in not only like pain that's in the chest, but could also be in like the left shoulder, in the neck too, which is interesting. Yeah. I did this, I did this. Okay, CPR. CPR is something I would encourage everyone to get trained in, even if you're not EMT or an EMR, because you could save someone's life in an emergency. CPR isn't as effective as we think. Like only 20% of CPR attempts actually resuscitate the patient, only because they're in such a dire scenario that even no matter your best efforts, it's hard to save them. And a lot of people do CPR improperly. But essentially, what it means is like, or when you do it is when someone's not heart's not beating and they're not breathing. So this I should have updated this. If someone's heart is not beating, like you can do compressions, but you shouldn't do like forced respirations. And if someone's heart is beating but they're not breathing, you shouldn't be doing compressions because you're like it's such a traumatic like procedure. Like you're breaking their ribs basically when you're doing CPR. So you shouldn't do it unless their heart isn't beating. What you do is you like first have to determine 100%. You want to look and see the lack of rise and fall in their chest. You want to put your finger right here to feel their pulse or feel the absence of pulse. And then you want to hear any breaths. So you're not going to feel breaths. So it's like look, feel, hear. You're just like laying over the patient. Your like ear is over their mouth. You're looking at their chest and you're feeling their neck. Once all these are negative, you're like, okay, this person needs CPR. First thing you have to do is call the ambulance, and you want to call for an AED, like an automatic emergency defibrillator, because while you're doing CPR, someone can get that set up to shock them. So when you do CPR, and like this training is not enough for you to actually know how to do it. I'm sure in your CNA class you've been learning this, but like you do cycles of 30 chest compressions and 2 breaths that are rescue breaths. This is different for an infant. It would be 15 to 2. But for an adult, you compress their chest to the beat of like staying alive. It's like 100 times a minute. And you want to go deep, like 2 inches deep. So you are most likely going to break their ribs doing that, but it's potentially life-saving and they can recover from that. And then after those 30 chest compressions, immediately you give them this like mask that's attached to a bag that's attached to an oxygen tank, and you're like squeezing the bag to force air into their lungs. And you like tilt their head back to open up their airway maximally. And then you go right back to chest compressions until the AED arrives. The AED is really easy. Like you actually don't need to be CPR trained to use an AED. Anyone can use it, and every building in like a public space has one. You just have to locate it. Like you just put the 2 pads on the person's chest and like side, and then you clear any bystanders, and then you press shock, and then the patient will be shocked once, and then you continue with CPR until the ambulance comes. Yeah, it's cool. I have not had to do it on a person, thank goodness, but it's a cool skill to know. Okay, let's see. Common myths that let's see, heart rate, blood pressure. I feel like, oh, these are interesting. Yeah, kids. So a myth that kids can't have like high blood pressure. Yes, they can. And actually, hypertension is more common in women than in men. Yeah, otherwise we can move forward. I think we're going to skip stroke, even though this is interesting too. Okay, last thing I wanted to tell you guys about was SOAP, which is actually a method that is used by medical students and even residents. Like before they start to have this like intuition about what's going on with the patient, it's just a very like sort of, it's a good way to organize your thinking. Like first you notice the subjective complaints of the patient, and then you have combined with the objective results to inform your assessment and diagnosis, and then your subsequent planning. So doctors in training are using this structure to guide their thinking and decision-making process. And it's, like I said, subjective is like the patient comes in and they tell you, this is their chief complaint. So signs are like basically evidence of a disease that's quantifiable by a test, and then symptoms are just complaints that the patient make that you couldn't necessarily prove. So like pain, a doctor can't actually like do a test on the patient and confirm that they have pain. That's something that the patient reports. So that's a symptom. Or like nausea too. Versus high blood pressure is a sign. So that's the subjective part. The objective is those vitals, any findings in a physical exam, an imaging result, any data, lab data that's taken about the like concentration of different cell types or proteins in their blood. And then they assess, they determine the diagnosis, and then plan. Talking about referring to a specialist, doing a procedure, giving a patient medications, etc. So we can do the SOAP method together if you guys want to participate. And then I have like a little activity after that. So imagine you have Mr. John Doe. That's just like the name for an anonymous patient. Jane Doe is the female equivalent. It's like you don't know their name when they arrive at the hospital. I did not know that until like high school. But so Mr. John Doe is a 58-year-old man, comes to the ER complaining of severe chest pain. It started 30 minutes ago while he was watching TV. And the pain is radiating to his left arm and jaw. He's sweating and feels really nervous. And he tells us he has a history of 15 years of high blood pressure, plaque buildup in his arteries, high cholesterol. He's pretty sedentary, meaning he's not really exercising the recommended amount, like 30 minutes a day, 5 days a week. He doesn't eat well, and he's this 1 pack a day smoker for 30 years. And what the 1 pack day smoker means is that I don't think wait, let me think. 30 pack day. I think he's a 30 pack year smoker. Okay, there we go. So he's smoking like 20 cigarettes a day. Lots of red flags here. Okay, I'm not going to show you this part until after. Does anyone want to tell me what they think some of the subjective, like in the SOAP diagnosis, like what would go into the subjective category based off of what you've learned here? Like things that he's complaining about, it could be his history, not something that the doctor could determine without the patient telling them. Does anyone have any guesses?
Could it be his lifestyle?
Yeah, that's a great one. Exactly.
The pain radiating.
What else is there? Also, his
Feels
nervousness.
nervous.
Yeah, exactly. He feels nervous. His smoking habit. What else is there?
Maybe
His,
how the contractions, like how far apart they are, like how he's feeling and stuff.
yeah, exactly. Yeah, the like time between his like chest pain episodes. Yeah, perfect. There you go. So it's what the patient reports and any relevant medical history. The medical history part, the high blood pressure and high cholesterol, that's more in the objective category. But the other two, definitely his history and the health behavior relates to subjective. Okay, now I'm going to tell you his vital signs. Oh, wait, give me a second, guys. I'm going to delete this, the answer, so that you can tell me if this is bad or not. I should have done this before. I forgot that they were showing. Okay, 1 second. Okay, ready. Share again. Okay, so here are his vitals. Can anyone tell me if he has a blood pressure of 185 over 120? First of all, do you remember what the two different blood pressures are called? Second of all, is this concerning?
It is concerning.
Big time. He's in hypertensive crisis. And they were called systolic and diastolic pressures. What about his heart rate? I remember I said 60 to 100 is normal for a certain condition. Anyone remember what? It's your resting heart rate. So he told us he was just sitting on his couch watching TV. So his heart rate really shouldn't be at 120 if he's not doing anything. That's a sign that his body is working hard to keep him going. His respiratory rate. I said this really quickly, so it's okay if you don't remember. Do you think 24 is within normal range? Yeah, it's above. It's elevated. It should be 12 to 20 and closer to 12 considering he wasn't exercising either. What about his oxygen saturation of 91%? Where should it be if everything was going okay with him? Higher or
Above
lower? Say it one more time.
Would it be above like 95%?
Exactly. His temperature is fine and his lungs sound good. So he's not 0 for 6, but he's not doing great either. Okay. Let's see. Wait, what is on this one? Assessment. Oh, okay, there we go. So I share back again. So here's what they diagnosed him with. Acute myocardial infarction, heart attack, probably caused by the plaque buildup in his coronary arteries, and some major risk factors, which maybe you identified from his history, was his habits of smoking and low exercise and poor diet. And so a couple things the doctors will do. First of all, they definitely need to address his like low oxygen saturation. 91% is really low. And that's dangerous because the brain needs oxygen to function. We don't want like tissues of the brain to die because that's irreparable, like not salvageable. If he isn't allergic, which they would check, they would also give aspirin. Aspirin's a blood thinner, so like an anticoagulant, because that may help improve blood flow. They could also do coronary angioplasty. That means placing a stent. So here you can see this diagram where you see like this like yellow plaque buildup in the artery. They're going to slide this tube that has a deflated balloon into the artery. They're going to blow up the balloon, and this will like push against the plaque and sort of widen and open up the artery. And then they're going to pull out the balloon, and what's left is just this stent that keeps the artery open, sort of dissolves. Let's see, what else does it do? It's also breaking up the clotted blood, and it's improving and restoring blood flow. And then he'll be monitored, probably put on like cholesterol lowering medications when he's released from the hospital. The stent actually stays in like forever. And he'll probably also be given, let's see, what else will he be given? Let's say here. There we go. Yeah, cholesterol lowering drugs and hypertension medications. There we go. There we go. He'll be definitely seen with a cardiologist like more regularly to make sure he's within healthy range. Cholesterol is a pretty easy, like by blood test, you can evaluate someone's levels. And they may encourage him to take on a heart healthy diet, to quit smoking, or at least to lower his number of packs he's consuming a day. And yeah, let's see. I think that's all we have. If you guys want to do, we can do this one last game and then I'll let you guys go or answer any questions. Does anyone want to answer the first question from the word bank? The heart has 4 blank enclosed by thick muscular walls. Yeah.
Is it chambers?
Boom. Nice. Next one. The upper part of the heart has 2 chambers called the right and left. They are receiving blood coming into the heart. What are? I can give you a hint. Starts with A.
Is it the arteries?
I heard someone else say atria. The atria, yeah. So the arteries are not part of the heart. They are just delivering blood away from the heart. So there's the right and left atria, which are in the upper part of the heart, and then the right and left. What are the right and left blank, which are the lower part of the heart? That's the next question. This one starts with V, so you have 2 options.
It's the ventricles.
Boom. Yeah. Okay. What is the short loop from the heart to the lungs and back again? It's not an actual loop. It's like a pathway. I'll give you a hint. Lungs. Like what is the scientific word for lungs? Because that is part of the word.
Pulmonary circulation.
Exactly. And the next question is, yeah, what's the other system that's going from the heart to all the other parts of the body and back to the heart? Sounds pretty similar to pulmonary circulation.
Systemic circulation?
Exactly. Okay. Blood vessels carrying blood away from the heart are always called what?
Arteries?
Yeah. And the other ones that carry blood back to the heart?
Veins?
Yeah,
Yes.
veins, I think.
Perfect. Okay. What are the tiny little vessels that deliver nutrients and oxygens to the cells and remove the waste products from the cells? I didn't mention these that much, but a little bit towards the beginning. They're the vessels that are responsible for this gas and nutrient exchange. Let's see, what do we have left? We have alveoli, capillaries, hypertension. That's kind of it. This one is the capillaries. What about the tiny air sacs that are in the lungs? It's like the smallest components of those lungs. The lungs actually are similar to the heart, to the circulatory system in that you have like the biggest branches, which in the heart is called the artery, in the or artery or the vein. In the lungs, it's called the bronchi. Then the next level is the arterioles, the venules, and the bronchioles. So it's like the LE helps you remember. It's this a little bit smaller. And then the smallest for the heart, the smallest vessels for the heart are the capillaries. And the smallest like divisions of these branches are in the lungs are the alveoli. his little air-filled sacs. So that's the answer to number 9. And then last one. So high blood pressure we know is hypertension. I gave you the answer, but I'll ask you this. What is low blood pressure? What's the like specific prefix that indicates low? It's okay if you don't know. I'll just give you guys a little bit. So it's very similar to hyper. It's just you replace hyper with hypo. That just means low of anything. You can also be
Hypotension?
exactly hypotension. Yeah. Perfect. I think that was all I had. If this was a live class, we would have had like the vital signs. Oh, I forgot to tell you the last one. Pupils. So you say like pearl, meaning PERRL, pupils equal, round, reactive to light. So you like have a little flashlight and you shine it in the person's eye, and you want to check that their pupil is like dilating because of so much light exposure. Like you don't actually need that much light coming to their eye. And then when you remove the light, you want to check that it's like expanding again. And then you want to check that it's the same reaction on both eyes. So if there's like only one eye that's responding on one part of the face, like that could indicate a stroke. When you have, for example, like someone who's overdosing on narcotics would not have this reaction to light, like their pupils just stay really pinpoint and don't change even when you do this flashlight test. And so that's concerning. And I can just pick up other things too. You also want to check, let's see. Yeah, that's it. That was all 6. So 3 pulmonary, 2 cardiac, 1 related to your eyes. Does anyone want to tell me the 3 pulmonary like vital signs? If you can remember. You don't have to say all 3, just one that you remember. What is the kind of vital sign that you take with a stethoscope? Oh, not with a stethoscope, with a cuff that can be either manual or automatic. What are you determining about the person when you do that kind of test?
Blood pressure?
Exactly. What's another vital sign related to the lungs? There's 2 more. One of them is related to oxygen. Does anyone remember what it's called?
Breathing
Oxygen
rate?
level.
Oxygen level, pulse ox, and then breathing, exactly, it's the rate of respiration. And then we have 2 for the heart. Does anyone remember those? Wait, what is the second one? Did I tell you that? Heart rate, blood pressure. Oh, I'm sorry. Blood pressure was for the heart. There's one left for the heart.
Heart
What are we
rate?
taking? Exactly, heart rate. I forgot one for the lungs. This one you use a stethoscope for. And some examples of pathologies are wheezing, rales, crackling. What are we listening for there?
The lung sounds.
Exactly. And then the last one is the pupils. Okay. That is all I had prepared. I'm sorry I kept you guys over. I thought it was gonna end early, but I just love talking about this, I guess. Yeah, if anybody has any questions about MED-UCATE more generally, I'm going to leave you guys my email. Actually, I'll give you guys my personal. No, my MED-UCATE email is fine.
I was wondering what year of college are you in? Or
Yeah. I'm a 3rd-year college student, so junior. I've been in MED-UCATE since my 1st year, and I was I became president this year. Yes, question.
Yeah. Or is someone going?
Oh, no, you can go first.
Okay. I had more of a general question. As
Yeah.
like the co-president of MED-UCATE at your university and a STEM major on top of that, how do you balance academics with personal life and
Yeah.
extracurriculars?
That is a very good question. I I'm very involved definitely on my campus. I'm part of my I was also artistic director this year of my like the largest dance company on my campus because I'm a dancer as well. And then I'm president of another student group too called Med Life that does like week-long service learning trips in South America to do like health volunteering. And I'm also a research assistant for around 15 hours a week in a cancer and immunobiology lab on our campus, um, which has been a struggle. Definitely, yeah. Pre-med is intensive. We have lots of science classes, more than like a typical science major would have, because medical schools have additional requirements. It's essentially been like I've learned that I need to take an hour a day to myself when I come home at the end of the day, to just have dinner and talk to my roommates and read and watch TV. And then really, like, during the week, it's just work, sunrise, sunset, but it's a lifestyle that I enjoy. I do activities that I make sure I like. I started a lot more things my first year than I'm doing currently now, because I just learned to prune down and pick the things that I'm excited to work on and spend long hours doing. It's not worth joining an activity for the sake of adding it to your resume if you're not passionate about the work and it just feels like a slog doing it all the time. So I've narrowed down onto the things that I believe like allow me to like, I really enjoy teaching and working with kids. I'm hoping to go into pediatrics. I'm hoping to teach, like, my gap year to teach English abroad. So being part of MED-UCATE is something I love doing, and I love creating the classes. And then ballet, of course, is a passion I've done for a long time. So I don't feel like I've compromised anything doing those. It's a happy use of my time. And then on the weekends, definitely, like, I think it depends maybe on the pre-med program you're in, and the college you go to, but it's rare for me to have a weekend day where I don't work at least for half of it. I just can't like give up my entire Saturday or Sunday just for fun. But I do always make sure, like, every weekend I'm seeing my friends for a couple hours, where, getting lunch together, going to ballet class, going out and seeing a show, going to the park. So we do it is like a sacrifice, that's for sure. But whenever I go home, of course, like, I'm fully out of school. Like, that is my time to go back and do what I love. Not that I'm not doing that at school, but you know what I mean. Um, it's I just think you have to sort of be like, you can't overcommit yourself either, just for the sake of being afraid you're not doing enough, because then you burn out quickly, and then you like no longer are excited to like start every week and see what you're going to learn. Yeah, I'm happy to talk more about though how I've balanced it all. Like, it was hard at first, definitely, because I was like, everyone seems to be doing so much and I have to do the same thing. How is everyone handling it? I need 8 hours of sleep, but I have friends who are only getting 6 hours. Should I only be getting 6 hours? No, you should not only be getting 6 hours just because two other people are doing that, right? Like, you got to do what's best for you to feel energized throughout the week. Yeah, sorry that rambled a little bit, but good question. Anyone else?
I just have like a general question. Where have you always like stick to like cardio and like pediatrics, or like did it take you like some time to figure out what you were like actually interested in?
That's a good question. I Pediatrics is something I figured out because I volunteer at the children's hospital at my university, because we have a medical center here. And I realized, like, I enjoyed being with patients at that stage of their life. Like, there was so much optimism, and they're like, the family network and support they have is different from an adult patient. And after realizing I was interested in pediatrics around my first year, I have shadowed different doctors. When I go home, I see if doctors in my area are available to take me on. It's very low key. I just ask them for a day or two of their time and I follow them around. And so I've gotten to see around like 12 to, I've actually know, maybe 12 to 15 different specialties, just like different days I've been home since starting my first year. So I think the best thing you can do is, because otherwise when you're researching, like, maybe you'll be in a lab with, if you guys decide to do research, maybe you'll be in a lab with a doctor or a PhD scientist, but they're only going to be in one specialty. So you don't get that much of an exposure to others. The best thing you can do is shadow, and you just have to be professional and polite about asking. You can use your family networks if you know people whose friends, parents are doctors, or you have your own doctor who you see like once a year. You can always ask them, and then ask them if they have colleagues who would be happy to take you on. And then just even a day is enough to learn about that specialty and then compare it to another, the lifestyle, the kinds of patients, the kinds of pathologies, the training it takes, and that helped me figure it out. I'm not set on cardiology. I just liked emergency medicine because I got my EMR license, but definitely pediatrics is something I'm excited to go into.
Did you take any internships in high school, or what did you do to stand out?
That's a good question. In high school, I did what was it? Molecular biology, like, what's it called? Not systemic biology, synthetic biology. I just don't do that work anymore, so I forgot the name. Synthetic, but like gene editing, like 3 week summer learning program. It wasn't an internship. It was just like the opportunity to take classes in a lab environment. But beyond that, I think the way I was able to stand out to U Chicago was just in the different organizations I was a part of through my school and outside of my school, just working hard enough to acquire leadership roles because there's so many transferable skills you learn from being a leader that even if it doesn't directly relate to what you want to study, like you can always make a convincing argument that it will make you a successful student in whatever program you decide to apply to at your college. So like I was working at like through a nonprofit that was organizing musical concerts because I played the piano too, and I joined this organization in my like county, and then I was director of my school's dance production, which I've continued to do here too, obviously, and was like like the head tutor at my school in the science department. So all these things, like things I was already naturally doing, I just looked for ways to become a leader in them, and then wrote about all of them. Yeah. Question, Ananya.
Did you know you wanted to be pre-med in high school? And like if you did, what specialty were you like really interested in?
Hmm. Yeah, I've known for a long time. I feel like I always like science more than anything else. I mean, I love history, but was like, could I do a career out of that I would want to do every day? No. So it was like medicine. I was always like, it's perfect because it's what I love learning about, and I can see myself doing it for the rest of my life. Specialty wise, I don't think I could have told you pediatrics in high school. And that really came about later. Like my parents are in the medical field, but they like I don't want to do their specialties. Um, like my dad is like my mom is an oral surgeon. My dad's a child psychiatrist, and like not, I don't want to do either of those. But beyond that, I was very open to anything else. And they don't ask you to choose your specialty until your third year of medical school when you're applying to your residency program. So there are plenty of my classmates who don't know what they want to do, and I don't know my subspecialty either. So there's no pressure to know in high school at all, or even to know that you want to be pre-med, because you can figure it out in like your third year and probably still graduate on time. It's better to figure out by your second year, I would assume, because there are a lot of prerequisite courses. But yeah, I know people who did it in their third year. They found out they're like, this is what's right for me after they discovered they were like, research is not my thing, but I want to stay with science. And then maybe they'll just take a gap year and like take the extra 2, 3 classes that were left over, and they're on the same track as everyone else. Yeah.
What college do you currently go to?
The University of Chicago.
Oh, nice.
Hmm.
I have another question. Do you think there's any like like a common misconception of like pre-med? Like you feel like a lot of your peers or like a lot of people who are interested in medicine seem to like
Mm.
believe.
Like what people believe about pre-meds who aren't pre-meds, or like okay, like that everyone's competitive and is fighting for one another to get into med school. Like I don't think that's true at all, because people I know, I'm not applying this year, I'm applying next year, but like people share their personal statements with one another. They give each other feedback. Like in our classes, we have PSETs every week in labs. Like we always work together. It is not like we are not treating it like a zero-sum game. There are only 10 people who can get A's and everyone else is on their own. So that I would say isn't true. The stereotypes that, let's see. Oh, one thing that's funny is like everyone thinks pre-meds are already doctors. So I have a lot of friends who ask me, like, what do you think I should do if I have chest pain? I'm like, I don't know. I'm like, I'm not a doctor yet. But I mean, if you're an EMT, like you can give a little bit more advice than the general pre-med student. Otherwise, we just learn about body. We just learn about like biology as pre-med students and chemistry. We don't really learn about applied clinical medicine. That doesn't come until later. So it's funny, like if you like hear a pre-med in college going around acting like they can diagnose someone, they really can't. They haven't learned about that. Um, Otherwise, let's see. What's another that people are yeah, that they're the most stressed people on campus, that they don't know how to like find a work-life balance. I absolutely don't think that's true. Like I have a couple of friends who are pre-med, they all ran a half marathon this morning. Like they've been training for weeks. Like everyone does so many other different involvements. They keep up their passion. So it's absolutely possible. Otherwise, you can't like I don't think you can be so single-minded for 4 years and not explore anything else you like. Like it's definitely you're gonna burn out that way. So yeah.